Welcome back, clinical problem solvers, to another RLR edition. No, you're not confused. It's Thursday, not Friday, but we're feeling giving this week, and we're going to give you two sessions with RR. And I've been told,
I'm sorry, this is my chance to interject. I waited so many years for this moment.
oh shoot, I'm already seeing it in the.
Okay, good. Thank you, Yusuf.
So I am confused. You know, oh my gosh, we're off to a rough start.
I'm not going to bail you out, Prof. Rez. I'm just
Yeah, I was wrong with the date, but I'm going to be even sharper with the diagnosis. We have a repeat case presenter. Ethan, unmute yourself and tell us how is your day and what time it is.
Hi everyone. I'm a medical graduate from Taiwan, so here's 2 a.m. And actually here's a typhoon struck yesterday, so it's
Oh,
raining
wow.
outside and the weather is not really good here, but hope everyone can enjoy the case and in their own room in comfort.
Ethan, why do you look more awake than I do? And it's two there. I look like I should be asleep. Anyways, your cognitive powers are sharper. Who's teaching today? Who's doing teaching points?
I'm doing it.
Oh, tell us, please, Vijay, tell us a little bit about yourself and what time it is.
Hello everyone, this is Vijay. I'll be doing the teaching points. I'm a critical care resident from India. It's 11:30 here at night. Fun to join another case.
No better way to do a nightcap with the case, huh, Vijay? It's gonna be good. And I'm realizing I'm speaking like my parents. So my parents are immigrants from Iran. And instead of asking what time is it, I'm saying what time it is. That's like what my parents would say, but it's all good. Who is scribing today on the whiteboard?
Hi, I'm A. I'll be scribing today.
Hey, tell us a little bit about yourself. What time is it where you are?
Oh, I'm not in St. Louis, so it's just 1 p.m. I'm not like in the nighttime. Yeah, I'm originally from VMR. Yeah.
Fantastic. Well, thank you.
I'm just interested in neurology, so I will be just applying neurology residency.
Oh, fantastic. We love our
Yeah.
neurology candidates.
Thanks.
All right. So Robbie, say a word, and then Ethan can present the first aliquot for you to inhale like you did that green Fuji apple.
Oh, wow. Your diagnostic skills are on point. We're in for a treat, y'all. Prof. Rez is hitting the money.
Someone's going to correct me and say there is no such thing as a green Fuji apple, but I don't care. It sounds fancy.
Hey, Prof. Rez, I believe it. You believe it. That's all we need. All righty, Ethan, take it away, my friend.
Sure. So this case is the most impressive case I encountered last year during my rotation. And we have a 59-year-old female presented with shortness of breath for 3 days. And the patient had been experiencing abdominal discomfort as well for the past week, and for which she went to a local clinic for help. And the endoscopy was done there, and she was told to have gastritis, and she was given esomeprazole, a protopump inhibitor. And 3 days ago, she started to have shortness of breath. And she also noticed that she had mild lower extremity edema. And due to the persistent symptoms, she went to local clinic 2 days ago again, at which she was told to have cystitis and medication was given, but there's no improvement on her symptoms. And the patient wasn't able to tell us what medication she received 3 days ago. And on review of system, she also had nausea, vomiting, dizziness, and poor appetite. And no headache, chest pain, orthopnea, fever, diarrhea, bloody stool, or melanoma. And that's the first aliquot.
Ethan, I think the first aliquot is a really illustrative of many instances in real life where if you're given the HPI on a piece of paper and you're devoid of the incredibly powerful information that you receive from looking and listening to somebody as you try to synthesize what they are saying, and you are putting it through the filter of what you can see, hear, or smell in the room yourself. You can see how it becomes a very challenging thing to decide what to focus on. And one way around that, and one way we ask patients to help us navigate what to focus on, is we ask them to outline their chief concern. And I think it's a very good strategy to ask patients when they have a lot of things, to ask, what are we going to work on the most today? Or what's bothering you the most today? To allow you to assign an amplitude of severity to each of these symptoms, which literally range from chest to toe and center on the belly. And I think what would really happen in real life, which I'll be authentic to, is I would try to study the severity of each of those things to figure out where the story begins and how to unravel it most efficiently from a diagnostic perspective. So if the same story is attached with the observation that the patient is going, that goes one way. If the same story is attached with the patient putting her hands over her lower abdomen and wincing in pain, then it goes another way. And so I think the only real progress that I would make with this information is to really realize that there are many, many ingredients here, and it's really hard to know what to tease out and focus on. And so the exam and the not just the exam really, but the general appearance of the patient and the observations you make will allow you to figure out where to go. So I think it's tempting to start with the shortness of breath, and do so because the patient is saying that that's her chief complaint and that's the most recent symptom. And I think the thing to ask from the get-go is, how does shortness of breath merge with abdominal pain? And I think it's very, very possible that all along this patient was having a thoracic problem that referred into the abdomen, or that this has been an abdominal problem that made its way into the thorax, either through aspiration from GI luminal pathologies, or through the leakage of fluid from either liver disease or renal disease up into the chest in the form of hepatic hydrothorax or nephrogenic pulmonary edema, or through many other mechanisms. And so I think right now, I would be having a little bit of trouble knowing what to invest in, and would make no assumptions about where the story begins or where the disease lies. I'm curious, Professor, how are you? Are you able to make more progress, or how are you thinking about it?
I just want to say, like, I just love the way that you said likely thoracic with referral to the abdomen, or less likely abdominal with now involvement of the thorax. And then I'm not going to say anything more, because I think it's so important before we invest our cognitive energy and bias ourselves to know what the problem is we're solving. And I don't think we have that data yet. So I'm going to leave it with your poetry, my friend, and ask for more information from Ethan.
So her past medical history, she had a transcervical uterine myomectomy 15 years ago, and she has a spontaneous abortion once. And for reference, she had 3 children. She was G3P2A1, and she currently has a daughter and a son. And her social history was unremarkable: no alcohol, no smoking, nor illicit drug use, and she had no known allergy. On her family history, her mother had diabetes mellitus, and her father died from colon cancers, and she was not taking any medications. And on her physical exam, temperature was 36.8, pulse was 105, respiratory rate was 13, blood pressure was 104/76, and SpO2 was 99% under room air. Head and neck exam was normal, not anemic, not icteric, and no jugular vein distension. A chest exam showed bilateral clear breathing sounds, and her heart exam showed regular heartbeat with no murmur. And her abdomen exam showed diffuse abdominal tenderness. And also there's mild lower extremity edema on her both extremities, lower extremities. And neural exam was normal. and that's the second endpoint.
Very helpful, Ethan. And the JVP was normal?
Yes.
The JVP, okay. Robbie, I'll just share my preliminary thoughts and then ask for you to layer upon those. I will just first say I love the word nil in social history. It just reminds me of soccer and like it originating in England. So huge shout out to Aya for putting in nil. The exam itself, boy, I think that, you know, honestly, when I first heard this story with shortness of breath, swelling in the legs, abdominal discomfort, I went straight for the heart and I prioritized congestive heart failure because it could manifest as such. But this exam where the JVP isn't elevated, though it's not perfect, and there is no crackles, I think it's pushing me away from left-sided heart failure. And interestingly, when I did see the lower extremity edema, I was like, well, once you get above 50, half the population has venous stasis. So maybe this is just venous stasis. And in fact, it's noise, not a signal to the underlying problem. The tachycardia is a red flag and tells me there's something happening in this patient. As of now, my intention really goes to the abdomen. And I feel like it's, you know, something you've taught us so well. It's so hard to make progress without imaging, particularly a CT scan in approaching abdominal pain. So really where my focus goes and where I think I would be pursuing the next series of tests would be a CT scan of the abdomen pelvis. The good thing about that too, it gives you that lower thorax and it might give us some clues to any kind of thoracic problem. But very curious from your perspective, both the past medical, it didn't really affect me, honestly. Like I'm tracking that stuff, but nothing to, you know, imprint on the foreground data. But would love to hear from you, my friend.
No, Professor, I completely agree with you. I think that like the most efficient pathway is to get a CT scan to understand what's happening deep inside this person's belly. My mind is so intrigued how to about this concept in general about how we try to predict the next set of data when we have one, and we ask, what do you think the labs are going to show based on what you've seen? What do you think the imaging is going to show? And sometimes based on the history, what do we ask, what do you think the exam is going to show, or what do you think is going to be most helpful? And it reminded me of that case of sigmoid volvulus that I presented to you, where you were like, it was just impossible to break the abdominal distension, and that was a real clue. Part of me is trying to imagine this patient in my mind's eye with a normal respiratory rate and an O2 sat, and try to merge that with the fact that she was saying she was short of breath. And so I'm just really intrigued by how it is so hard to predict most of this history based on this exam, like to go backwards and be like, if you handed me this exam and said, this is the vitals, this is the exam, what would I predict that the history is? And I would predict that the patient probably said she has abdominal pain, and based on the diffuse and severe nature, it's probably acute and she's probably nauseous or vomiting. I would never have predicted that that she has shortness of breath. And so what does that mean? I guess it might mean that we should minimize its significance and ignore it. But when you realize that the patient said that that was her chief concern, it then reminds you that we haven't really challenged her thorax much. So what I would do is this patient probably needs to go into a bed. And if she didn't arrive by ambulance, she has to get there. And so you have two options of taking this patient into an ER bed. You can put her in a wheelchair and wheel her there, as is likely the case for most patients. But I would take the opportunity to walk with this patient, because I think the exam at rest might significantly underemphasize what she is reporting on her. And if she is not able to make it over there because she's tachypnic, all of a sudden you might get a CT chest, abdomen, pelvis, or you might really start to rethink things. So that I'm just intrigued, Prof. Rez, by how there is a disconnect between the history and the exam. And it might be because the history is probably something we shouldn't emphasize, or the exam is not representing the pathophysiology that we have here. So I'm really excited to see how this case evolves. All right, Ethan, tell us more, please.
Yeah, so in this report, I'll give you the first set of lab at ED. And white blood cell count was 13.3 with 93.9% of neutrophils. And hemoglobin was 13.2, and platelets was 27,000. So low. INR was 1.3, APTT was 26.9 seconds. Fibrinogen was 201, and D-dimer was over 10,000. Her creatinine was 0.69. AST and ALT was mildly elevated. I don't have the exact value here, but it's mildly elevated. And total bilirubin was 1.4. Sodium was 142. Potassium was 4. The CRP was 46.5, which is elevated in our labs. And the LDH of 1020 and heptoglobin less than 7. Lactate was 10.1 milligram per deciliter, so not elevated here. And chest X-ray showed
Oh no, I think Ethan froze unless I'm frozen right now.
He has us at the edge of our seat.
Oh,
Those are like some striking labs, man.
All right. Talk about not being able to predict anything. Oh my gosh. Maybe we can give him a second, Prof. Rez.
I think
Yeah,
yeah.
yeah,
Wait,
Ethan,
where's that?
you froze when you were just about to tell us the X-ray result.
Yeah. The X-ray was normal. No lung lesions, no cardiomegaly, and no blunting of CP angles. And the lactate was not elevated as well. Yeah.
Was normal, huh?
Yeah.
Maybe, Ethan, I can just ask one favor. Do you mind just sort of summarizing the pertinent labs that were abnormal? Because I think it was a little glitchy. What
So
got you as abnormal in this aliquot?
So thrombocytopenia and leukocytosis with neutrophilias and renal function and liver function was normal, and she has a elevated LDH and low heptoglobin, so likely has a hemolysis patterns and elevated CRPs, and also, and let me check, also a elevated D dimers as well, and slightly elevated bilirubin, so a early DIC pattern. Yeah.
Thank you so much, Ethan. Prof. Rez, I think you should take this one.
Oh my gosh. Okay. Let's tag team it though.
Okay.
Let's tag team it. And what I'll do is I'm gonna focus on the LDH and haptoglobin, Robbie, and I would love to pass it to you to interpret the CBC and D dimer, like later on that. Because one of the things I really, first of all, Ethan, like just very surprised by these labs. There's no chance I would have predicted this amount of abnormality, but it's fascinating. So we have a normal hemoglobin, but we have a low haptoglobin. And so the question becomes, can you have hemolysis with a relatively normal hemoglobin level? And the answer is yes, you can. But then the other question becomes, can you have a very low haptoglobin and not have hemolysis? Yes, you can. And the instance where you can have a really low haptoglobin without hemolysis is if you have cirrhosis, because haptoglobin is in part synthesized by the liver, but there's very few instances in which the haptoglobin is undetectable and there's no hemolysis. So I want all of you to remember this. When that haptoglobin is that low, the liver is not cirrhotic. Even if it is, you have to think about hemolysis. It's a very sensitive marker. And the inverse is true. If the haptoglobin is normal and you're thinking about hemolysis, it's probably not hemolysis. The instance in which you can have a normal hemoglobin and still have hemolysis, which I think there's a lot of argument for hemolysis here, is when you're dehydrated. So everything is a bit concentrated. Didn't Ethan tell us that this patient was having vomiting, dizziness, abdominal pain? So probably wasn't keeping up with fluid intake. So I bet you these labs, the platelet, the white count, and the hemoglobin are overestimating. They're just concentrated. The other way you can have hemolysis and a normal hemoglobin is if someone has really good reticulocytosis, and so they're just replenishing the drop in hemoglobin, and it's not that severe of hemolysis. But I bet you as soon as you give this patient fluid, that hemoglobin is going to drop to 10 or so. So the low haptoglobin, the high LDH, and the thrombocytopenia, everything is yelling hemolysis. Rabih created a really cool LDH figure, and at that peak of the pyramid, in that order, you first have to ask, is there hemolysis or not? Then you can ask, is there infarction of tissue or not? And then you can ask, is there a cancer or not? But I'm stopping at that first tier and saying hemolysis, and maybe I'll just take it a little bit further and give a framework for like my approach to hemolysis, and then pass it to Rabih to take it further. I think the best way to think about hemolysis is not, is it intravascular or extravascular? And by the way, when you do have hemolysis and you start breaking down hemoglobin, haptoglobin binds with hemoglobin to protect the body. And that's why the haptoglobin level is low, because you don't want that insult that comes from hemolysis. I don't like thinking of it as intravascular and extravascular. I just like to think of it as, is it something inherently wrong with the red blood cell, or is there something wrong with the environment? And when you approach it as such, you start realizing that, boy, the peripheral blood smear is probably the most important test you can send when you're contending with hemolysis. And when you think about the red blood cell itself, you can think about the surface. So, for example, if someone has hereditary spherocytosis, an enzyme deficiency like G6PD, or even a hemoglobinopathy like sickle cell disease, in the environment, it's MAHA, autoimmune hemolytic anemia is a very common culprit. And you can even have like electrolyte stuff and infections that can do it. But I'll pass the mic to Rabih to both comment on, is he sold? Is this hemolysis? And then how does the thrombocytopenia, D-dimer, and CRP help us make progress on that new problem we're trying to solve?
Oh, Prof. Reza, I think that's a very astute analysis, and I'm right there with you. And I think at the end of the day, as we start to move forward, I think what we can say is now the HPI makes sense and the exam makes sense. Because essentially we were trying to figure out if this patient has radiating disease from one organ to the other, but we found a really elegant way why everything may be affected. And that's because we've localized the problem to her blood vessels. And her blood vessels permeating through her chest, her abdomen, and everywhere else is causing problems. And so I think before we focus in on understanding what is happening at a microscopic level and really study and zone in on the cells, either in the environment or intrinsic to them, I think the emergent management takes a moment to reflect on, could this person be having any macrovascular complications? Just 24 hours ago, we heard about a patient with a blood problem, a JAK2 mutation that caused a macrovascular phenomenon, a portal vein thrombosis. So I think as we analyze this case, part of me is wondering, hey, does she have a pulmonary embolism? And that's why she is tachycardic, has soft blood pressures, and had shortness of breath. Is she having mesenteric ischemia? So that would be sitting on my mind, and I probably wouldn't be able to move forward without at least pursuing or thinking about those hypotheses some more in the context of her D-dimer being through the roof. But I think, Prof. Rez, as you said, we have hemolytic anemia, and I think your question about how does thrombocytopenia help make progress, I think for me, it just helps me become regimented in how I evaluate hemolytic anemia. And so if we make in front of our mind's eye 3 categories of hemolytic anemia, either a problem purely in the environment, a problem within the red blood cell, but on the outside of it, on the membrane, or a problem on the inside of it. And if you take that visual of environment, membrane, inside, how does the presence of concomitant thrombocytopenia influence that DDX? It actually is compatible with a process in all 3 sites. So on the environment, you can have a microangiopathic hemolytic anemia like DIC. On the membrane, you can have autoimmune hemolytic anemia and autoimmune thrombocytopenia occurring simultaneously in a condition called Evans syndrome. Or you can have invasive parasitic disease, often, like malaria or babesia, that crushes both red blood cells and platelets. So each of those three categories is possible. The question is, which of them is most likely in the face of concomitant thrombocytopenia? And I will just say that Evans syndrome, the middle category of a membrane, is much less common than it is to have an environmental problem or an infection. In other words, developing two completely separate antibodies is a much lower probability event than one kind of infection like malaria destroying the red blood cells and the platelets at the same time, or one kind of environmental problem like DIC simultaneously destroying the platelets and the hemoglobin. So for me, the presence of thrombocytopenia is compatible with all mechanisms and forms of hemolytic anemia, but it requires much more to ask the body to make two separate antibodies attacking the membrane. So it really prioritizes environmental causes and infections. Both of those categories are very, very lethal the longer they're untreated. So they have to be tackled with equal fervor. And the good news is that once you have a blood problem and you've identified it as a blood problem, the solution tends to be obsessing about what's wrong with the blood. And the first step is to look at it and see what you see. If you see spherocytes, schistocytes, or intracellular organisms, that can help you make a tremendous amount of progress. And so all I would want to do right now is to not get obsessed with the blood and make sure there isn't a macrovascular complication, and then to get really, really obsessed with it by studying on the peripheral smear what clues I can see to the underlying process. And I think we'd be able to make a lot of progress with those two things. Anything else you want to add, Prof. Rez, before we hear from Ethan?
Nada. I can't wait to get more information. But I agree. So you're probably scanning this patient, chest, abdomen, pelvis, contrast, and maybe also looking at the venous phase of the mesenteric vessels, just to make sure there isn't clot. Because I think, yeah, it's like with that very high D dimer, it's a really good hypothesis. Even if it doesn't pan out, I think we got to rule that out.
Sure. So we got a peripheral blood smear which showed rare fragmented red blood cells, and they think TDPs are likely here. And then we have a abdominal CT with contrast I would like to share.
So Ethan, it seems like there's a lot of clot there in the vessel. If you can go back to where there's that filling defect,
Yeah, I'll play it again.
and then you can pause it for the audience to see where the filling defect is.
So actually there's filling defect in RA as well. And also there's in IVC as well. There's a lot of spots in there.
So can you summarize for us, Ethan? RA, IVC, and where else?
Yeah, I'll give you the full interpretations. So the interpretation is there's also some diverticulitis and there's massive thrombus in IVC and RA. Okay. So, and then they got a CT angiography, which I don't have the image here, but I'll give you the interpretation directly, which shows persistent filling defects in RA and RV and along IVC and bilateral iliac veins suggested of thrombus with interval progression in size and distributions. And then there's also increased mesenteric stranding at upper abdomen and mild amount of ascites and swollen bowel loops. They suspect due to congestions. Also, there's heterogeneous liver parenchymal and periportal edema. Also, they think it's due to congestion. And also there's wall thickening and edema of gallbladder suspects due to congestion as well. And then I also had some information for the rest of aliquot. So also they did a TTE, which shows an ejection fraction of 75% and normal LV and RV systolic functions, mild TR, MR, and AR, and floating thrombus in IVCRA and RV. And then CVS was consulted, and they do not suggest surgery right now due to extensive thrombus, and complete thrombus removal is not possible here. And so heparin line was added to keep APTT to 1.5 to 2 times range. And the patient and her family was informed about the high risk of pulmonary embolism. And if RV fails in the future, she may need urgent surgery to remove the embolism, and due to ECMO being contraindicated here, and the death risk was really high. Yeah.
Wow, I think this is a mind-boggling aliquot and a very very unexpected and a really morbid turn of events. Maybe we can share this the screen back again so folks can see the data, but maybe I can just take a moment to sort of update our problem representation, because I think the case got complicated. We have a patient who so far doesn't seem to have a super relevant medical history, who presented with essentially an acute syndrome from chest to abdomen to pelvis, who was found to have hemolytic anemia and thrombocytopenia, and then was found to have extensive venous thrombosis from the iliac, IVC, RA, and RV. And I think the thromboses really probably are the center of it, and understanding why this patient is clotting will ultimately be the crux to the case. I'll pass the mic to you, Prof. Rez. How are you thinking about it? What's crossing your mind? And
I'll tell you something that was like, I think our initial concern that there was congestion was spot on, because we were trying to link like shortness of breath, abdominal pain, but who would have thought that the congestion is due to a problem with the vasculature, not because of the heart, but because of clot. But if you just go back to that first aliquot, it's just striking that like both our minds went to like something is congesting, right? But if you think about it, that's exactly what's happening here, except it's not the heart, it's what's happening in the IVC. And so the question becomes the following: why does this patient have such extensive venous thrombosis? And I think it's helpful to classify it as such, because the DDX is a bit different if you have arterial clots versus just venous clots. But this is extensive venous clots, and it's worrisome. It's worrisome because if that clot in the RA goes in the RV, then it's going to go into the pulmonary artery, and it can result in sudden death. So then the question becomes, why do people clot? And what's most likely happening in this patient? I don't think it's efficient to ask that question, like, why do people clot? There's a lot of reasons people clot, but we have another striking finding in this case, and that is microangiopathic hemolytic anemia. So now, Robbie, like the way I'm updating my problem representation is someone who was generally healthy, coming in with severe venous thromboses and microangiopathic hemolytic anemia, like the two together. And how did we arrive at the diagnosis of MAHA? Is because we have thrombocytopenia, elevated LDH, and most importantly, we have schistocytes. So then the question becomes, what causes MAHA and can also explain thrombosis? I think taking a base rate approach to MAHA is the way to go, meaning that the top 3 causes are TTP, HUS, and DIC. When you think about thrombosis in MAHA, TTP is a very good fit, especially like if you have arterial clots. However, nothing else about this patient, it's not arterial clots. Furthermore, they don't have any of the other findings we expect with TTP, the neuro findings, the fever, and the platelet counts tend to be very, very low. HUS is more of like a renal manifestation. The story just isn't consistent. And DIC, the fibrinogen is elevated. That doesn't exclude DIC. And remember that DIC can be linked with thrombocytopenia, can be linked with small microthrombi. But boy, these are huge clots. And the patient doesn't really have any story to suggest DIC. But if ultimately we diagnose a cancer somewhere, cancer can lead to DIC. Cancer can make someone hypercoagulable, and it can fit each of these, and it can lead to schistocytes. But then when you go beyond the base rate of MAHA, there's like one diagnosis that really all of us should think about in a patient with such severe clot. And this is where Rabih, like just tracking the past medical history, and you see there's issues with pregnancy there. And now you wonder, could this be antiphospholipid syndrome? So what would that prompt my mind to do? It would prompt my mind to look at that PTT from prior labs, because you have something in antiphospholipid syndrome. You have antibodies against phospholipids. This causes a prolonged PTT, not because the patient is coagulopathic. It's not that they're at risk of bleeding. It's the opposite. They're actually at risk of clotting, but it's an issue with the lab and the antibodies to the phospholipids. So the next steps would be a lupus anticoagulant, cardiolipin antibody, and the beta-2 glycoprotein antibody. And if this is what I'm concerned about, Rabih, like I think I'm most concerned for APLS, then the thing to note is that many times with APLS, their index presentation to the hospital is catastrophic APLS, where you just have clots everywhere. And but only 1% of patients with APLS per that illness script actually have catastrophic APLS. But the 50% that come to the hospital with new diagnosis of APLS present with catastrophic APLS. So my next steps, in addition to the management steps that Ethan mentioned, which are phenomenal, like can we remove this clot? Can we place this filter? It would be to anticoagulate this patient for sure. And it would be to work them up. Primarily for antiphospholipid syndrome, I just don't think this presentation is as compatible with TTP. And then how do you manage it? This is a patient where like Lovenox might not be the right drug. We learned recently that if you have single positivity on the APLS labs, you can do Lovenox and heparin and such, but it's really Coumadin for this patient like long term. So Rabih, I'm going to give the mic to you, see what you think. And we know that APLS can be associated with other autoimmune diseases like lupus. So sending that ANA and knowing that there are associations of antiphospholipid syndrome.
Prof Rez, that was absolute poetry. One of my, I don't know, maybe one of my favorite Prof Rez magic tour de forces I had. Literally nothing to add. That was beautiful. Ethan, what do you have next in store for us?
Yeah, just to clarify, the first peripheral blood smear show rare schistocytes. So in the first peripheral blood smear, they think TTP is unlikely. Yeah, but they still send NMTS 13 level because that takes time to come back.
Ethan, can I share with you one of my favorite quotes? And Rabih knows what I'm about to say. It's from the great Dr. Bell, who was a Hopkins hematologist who passed away. But he, and I want to share this with the audience, I think it's such a good quote. One schistocyte in the right context is one schistocyte too many. So even if it's rare, if you have one schistocyte and you have that whole idea of waiting for the pentad, it's not helpful. UCSF came up with the triad for MAHA, and that's thrombocytopenia, high LDH, and even a single schistocyte.
So we did some further work up, and PNH phenotyping or paroxysmal nocturnal hematuria phenotyping was negative. And because we were unsure about if she had recent exposure to heparin, we sent a PF4 IgG, which was negative. And direct and indirect Coombs test was negative. ANA was negative, anti-dsDNA was negative, anti-cardiolipin IgM was negative, anti-cardiolipin IgG was negative, anti-beta-2 GP1 IgM was negative, and anti-RNP, anti-ribosome P, anti-Smith, and lupus anticoagulant was all negative. And C3, C4 was normal. And we also sent a set of tumor markers, which include CA199, CA153, alpha fetoprotein, and CA125, which was all within normal range. And protein C and protein S level was both normal. And the antithrombin 3 level was 28.4, which was low. The normal level was 75 to 125. And Shiga toxin E. coli multiplex PCR was negative, considering atypical HUS here. And blood culture was negative. HBS antigen was negative. Anti-HCV was negative. EBV, CMV, parvovirus serologies were all negative. And then they do a follow-up peripheral blood smear, which showed 2+ of schistocytes, but ADAM-TS13 level comeback, which was normal. And we had a JAK2 mutation test, which was also negative as well. And then I want to add some hospital course. So the patient was admitted to ICU, and 2 days later, the patient developed obstructive shock, multi-organ injury, and DIC. And DNR, which stands for do not resuscitate, was signed, and supportive care was given. And with supportive care, her liver and renal functions improved, but follow-up CT angiography showed progression of thrombus over RA-RB to suprarenal IVC. And there's a new right iliacus hematoma, which we suspect due to thrombocytopenia and the CVC puncture, the femoral vein CVC punctures. And also there's bilateral pleural effusion and massive ascites developed. And CVS was consulted several times due to the extensive thrombus, but still due to the risks, the surgery was not recommended. And a bone marrow biopsy was contraindicated at first due to severe bleeding tendencies, but was done eventually and showed normal cellular marrow and normal morphologies. And about 1 month into admission, she had conscious change and decreased muscle power on her right side. And a brain CT was arranged, which showed large recent infarct involving left superior frontal and parietal regions. And CVS was consulted and held a family meeting for the patient regarding the benefits and risk of a possible surgery. And they preferred to receive hospice care at home. So they discharged against medical advice. And 1 day later, the patient changed her mind and expressed that she wanted to receive the surgery. So she came to ER for help again. And then CTA was arranged. And that's the end of this aliquot. And next aliquot will reveal the final diagnosis.
Ethan, I can see why this may be your most enlightening case as you started us off with. And I think that, when we were huddling beforehand and you mentioned this was your 8th case, and I think with every single case, you're showing us just how much your presentation skills have developed. And to be able to narrate a story like this over months and be able to extract the learning that you've given us the pleasure of for the last 48 hours is a monumental effort. And I think this is an incredibly tragic and at the same time educational and fascinating story. And I think the story can only be so good as the way it's told. And I think you're really honoring and respecting both the patient and the beauty of medicine here with incredible. My only complaint is that you keep using the word negative, 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 negative. And I was hoping at least one positive, but no, we're in the world of negative, negative, negative. And I think what that helps us make progress from diagnostically is to take the space that Prof. Rez entered us in, which is that this patient has a really hypercoagulable condition, and ask ourselves, what would serologically not be negative? What would still be at play, even with extensive blood serologies? And I think you have to wonder, has this patient, and we can just go ahead and label this problem space kind of maybe creatively and not in any published way as a really or ultra hypercoagulable condition. given how much thrombosis this person is having, including the RA, RV, and the arterial side now. So I think we can all agree that this is a super hypercoagulable condition. And then a paradox ensues. How can you have a bonkers coagulable condition, but at the same time have no idea where it's coming from? That disconnect, I think, will allow us to make a lot of progress. So instead of being frustrated, as I initially was, that there is no negative, there everything is negative, I think it is a fundamental paradox to say, you're clotting left, right, and center, and yet I can't find the cause. Cryptic, ultra hypercoagulable. And I would venture to say that cancer is the most common cause still, but it would be incredibly unusual for cancer to present so acutely. This person was well 1 week ago. So while a cancer is very possible, probably the most common within the world of cryptic ultra hypercoagulability, its probability reduces in an instance where the patient does not have time to develop a cancer of this magnitude and proportion. So what could evade our detection that is very much possible? And I think the myeloproliferative neoplasms are sometimes triple negative, meaning that their JAK2 is negative, the calreticulin is negative, and the the MPL is negative. But here, MPNs don't cause a MAHA, and they certainly don't cause and present with a normal bone marrow. Heparin-induced thrombocytopenia, believe it or not, can occur without heparin exposure from the body, from the world, because your body can make heparin, and you can develop a thrombocytopenia as a result of an antibody to your own body's heparin released from your mast cells. So heparin-induced thrombocytopenia can occur. But the PF4 test that you said, Ethan, is almost 100% sensitive. What's the sensitivity of serologies for antiphospholipid antibody syndrome? About 90 to 95%, meaning that there are 5% of patients who have APLS who have negative serologies. And in fact, there is a second tier of serologies that are now increasingly well described. I forget their names, but I know they exist, that are bridging the gap between false seronegative APLS, in which case these antibodies are positive, there's 3 of them, and true seronegative APLS. So APLS is still totally fair game, and probably the most likely explanation for the overlap of microangiopathic hemolytic anemia and thrombosis. Because what we've done is we've essentially ruled out TTP and HUS, the most common causes of MAHA. In the realm of thrombosis and MAHA, things like myeloproliferative neoplasms, Behçet's disease, Vexus syndrome, don't cause a microangiopathic hemolytic anemia. So I would probably say that a disease that shows up, causes clots so devastatingly so, but doesn't really do anything else, and is hard to find, would have me still stubbornly concerned that this patient has APLS. And I would look up and then send for the subserologies that are part of that second pass workup. And I would maintain vigilance for cancer emerging. But practically speaking, how to actually manage a patient still clotting through their heparin is a nightmare. But there is some conversation in the world of catastrophic APLS for the role of steroids and other immunomodulatory treatment. And there is the possibility, of course, given the platelet count, very tricky, of plasmapheresis. So in terms of action steps, I think those antibodies I would think about, and then therapeutic steps, immunosuppression, plasmapheresis would be crossing my mind. Rambled a lot, Prof. Rez. Where are you at?
Dude, I just love that you have such deep knowledge of those obscure causes of thromboses, from like PNH to other etiologies, and saying how it's less likely to be those And there was a good question in the chat about the antithrombin 3. I will tell you, recently we had a patient with a portal vein thrombus that caused a hepatic infarct. That patient also had a low protein S, but there was no way that like protein S deficiency would explain such severe clot. I don't know the case with antithrombin 3, but I don't view it as hypercoagulable in itself to be explanatory of such severe thromboses. So I think it's really important, like when you see these abnormalities, to raise the question, but then ask, does it match the presentation? Would antithrombin 3 explain all this devastation? And I don't think the answer is yes to that. So even if that was low, it wouldn't dissuade me from APLS. I know that this is the fact with protein C and S deficiency. Does that also apply to antithrombin 3, Robbie? Do you associate that with more of a mild, increased risk or?
Yeah, I don't know, Prof. Rez. Yeah, it's a knowledge gap for me, and I'm definitely excited to plug it, but I'm not sure.
Yeah, if I were to guess, I would say probably not, honestly. Like I think it's APLS. And I bet you if we Googled that, they'd be like, yeah, it's makes you a little more vulnerable, but in itself wouldn't explain such a presentation.
Yeah, I think that like the only esoteric thing just to throw out there is that heparin works by using antithrombin 3. So technically, if you have I have some vague knowledge that I've completely lost, but I've definitely discarded it for a reason. So probably should keep it discarded now, but maybe refresh it after this conversation is over.
Love it. So it could just be the effect of the anticoagulation that was administered to this patient.
So after she come back, we did another CTA, which showed again thrombus in right hepatic vein, IVC and RA. And there's a newly found infiltrated lesion involving S7 and S8 of the liver. And the findings suggest HCC with tumor thrombophlebitis. And there's also bilateral pleural effusions and a small lung nodule at right upper lung, suspect lung metastasis. And then a MRI of liver was arranged, which showed a 1.4 centimeter nodule in S8, abutting right hepatic vein and IVC. So the radiology thinks it favors HCC in S8 with invasion to right hepatic vein and with diffuse tumor thrombus in IVC and RA. And we sent a serum PVA-Ca2, I think, in US, which that's more well known as DCP, the Des gamma carboxy prothrombin level that was tested, which has a high specificity for HCC, and the level was 336, the normal level being less than 28.4. So the final diagnosis is a hepatocellular carcinoma. Yeah.
Ethan, really, I'm very sorry for the patient that they have such extensive disease, but fascinating case with so many learning points. It's really, really incredible from a learning perspective. And we did say that, Robbie, in that discussion, that this could be consistent all with extensive cancer. And we would work up that patient with the cross-sectional imaging. I guess I sort of assumed there wasn't any metastasis based on all the prior studies, but that was a wrong assumption to make because we weren't really looking for that. And in retrospect, maybe if you go and review those studies, there might be, clues that in fact there are evidence of metastasis. But I think our mind was fixated on that. But as we said, cancer can cause DIC, cancer can cause schistocytes, cancer can lead to hypercoagulable state. Thoughts from you, my mathematician?
Oh man, I'm just gonna show you put up a visual to remind people that ultimately, in most cases, base rate wins. So this is the space that we were in, right? The most common by far and away is cancer, cancer, cancer. I guess the question is, and I think the assumption that I made incorrectly in this case was that the patient was well a week ago or 2 weeks ago. And it might be true that is the case. And I think the assumption that I made in my mind was for somebody to be this hypercoagulable from cancer, that they have to have very evident cancer. It should be obvious. And now I'm really curious to actually, because I know I just made that assumption from just not actually reading, but just like cases I've seen, like patients who really clot, it's often not hard to find their cancer. And that is part of why if patients have a clot and they don't have anything obvious, you shouldn't even look for cancer in the first place. And the very assumption that somebody can have such disproportionate hypercoagulability from a very occult cancer that requires the passage of a whole month and an MRI to detect is very intriguing to me. And I'm fascinated by that. Because if you told me a patient has HCC and has clotted everything off, and I would probably imagine that HCC could have maybe been even seen on exam and palpated, let alone be missed on a CT scan initially that saw the clot, but not the cancer. So I'm wondering whether this person has metastatic HCC all along, but as Ethan said, the pattern of metastases was to actually invade the IVC and the hepatic vein, and that everything that we saw wasn't actually clot, it was tumor. And so part of me is wondering whether I was just solving the case wrong and thinking, what is causing a thrombosis? But in fact, all that stuff in the blood vessel was cancer. And I've actually made this mistake before, Prof. Rez. I had a patient on LTU who had a portal vein thrombosis. Only maybe a week later did we realize that that actually was not a thrombus, it was tumor. And the way we knew that is we got a repeat ultrasound to see if the clot had gotten worse on anticoagulation. And when they did an ultrasound with Doppler, they were like, hey, I see arterial flow in this thrombus. This thrombus is being perfused. It's a tumor. And so I'm wondering, Ethan, if that was how you all putting it together, that actually this was just cancer in the vessels rather than it being a ultra hypercoagulable condition.
Yeah, I think that's a cool thought. But when I met this case in cardiology rotations, and all the team had no idea what the patient had, and I checked her chart after a few months for curious about what happened to her and whether they got the final diagnosis. And then that's where the MRI and low liver was done, and the repeat CT showed the HCC. But I think the initial CT contrast with abdomen showed no enhancement, but filling defects in the vessel. So I'm not sure if that was tumor, but I think I would favor thrombus there. Yeah, but I like the thought of you like emphasizing on base rate, because with all the negative workups, I will have to think if there's something else we could look up for cancers. And in this case, if the patient didn't even come back to another ED visit, we will never know what the diagnosis is. Yeah, and this is such a tragic case for a patient who was actually previously healthy. Yeah, and she was a fighter, and really want to present this case for the sake of patient, and I really want to thankful for this space for me to present it. Yeah.
Ethan, you're enlightening us so much, and I hope you inspired others to do the same. I think there was so much learning in this case. Most of us probably don't have a case that's so rich and so educational, but there are aspects of every case that we can learn from, and I really appreciate you bringing it here. All right, Vijay, you have the not enviable task of telling us what you learned today. The mic is yours, my friend.
Thank you so much, Ethan, for such a wonderful case. So we had an elderly female presenting with multiple symptoms. So whenever there is multiple symptoms the patient has, it is important to focus on the chief concerns and assess the severity of each that can lead us towards where we put our money on to further evaluate the patient. So this patient had shortness of breath and abdominal pain. So we were thinking whether it is a thoracic process leading to referring to the abdomen, or it is primarily an abdominal process getting referred to the thorax, which finally was considered as congestion due to a clot, which we saw further on. And given the history and the large disconnect between the exam and the history, so Rabih taught us that sometimes the exam may be misleading. So making the patient walk or putting them through that stress may unmask some findings that can be seen. So the labs are were very remarkable. So there are pearls that were shared was the patient had the normal hemoglobin with a low haptoglobin. So two or three possibilities when this scenario, this picture comes wherein there is a low haptoglobin and we are considering there is no obvious hemolysis. That is only one possibility, that is cirrhosis, because haptoglobin is being synthesized from the liver. The other possibility is this patient having a normal hemoglobin, low haptoglobin. Three possibilities. One is the patient can have an ongoing hemolysis, or the patient has excessive reticulocytosis that compensates and produces a normal hemoglobin, or the patient is relatively dehydrated that gives a false appearance of hemoglobin being normal. So how do we think of hemolysis? So rather than the routine thinking of intravascular is extravascular, it is more efficient to make it as a pure RBC defect or there's an environmental defect. RBC defect can be surface or hemoglobinopathies or enzyme defects. Environment can be MAHA or autoimmune hemolytic anemias or infections. So the money would be in using a peripheral smear to look for spherocytes, cystocytes or infections. And adding thrombocytopenia to this hemolysis. So all three mechanisms of hemolysis are possible, but environmental, it is very unusual for two antibodies to form against both WBC, against both platelets as well as hemoglobin for it to have a autoimmune hemolytic anemia with a thrombocytopenia, which is an Evans syndrome. So most likely it was concluded as there is an environmental defect. And given the huge lactate and hemolysis, it is very crucial to look for macrovascular complications like Rabih taught us. So very important is a thrombosis at multiple sites, whether it is pulmonary, mesenteric or portal vein. So this patient had an extensive venous thromboembolism with a microangiopathic hemolytic anemia, and the patient seemed relatively preserved. So first things we think of are TTP, HUS and DIC. So for TTP, the signature against it was there is no significant renal or CNS involvement. And it is important to remember that DIC, normal fibrinogen levels, does not always rule out DIC. And because this patient had pregnancy losses in the past medical history, it is very important to think of catastrophic antiphospholipid syndrome that can cause multiple thrombosis in multiple organ systems. So it is crucial to look for a baseline APTT levels. And David taught us in the chat that there can be a false normal APTT levels in acute thrombosis, and it is crucial to repeat it, repeat the labs and follow. And a very important pearl that was shared was one cystocyte in the right context is one cystocyte too many. So the triad of LDH, high LDH, low platelets, and one single cystocytes also has to activate our thinking process for a MAHA. So this patient on evaluation had multiple thrombosis in the RV, that was thrombus in transit, in the mesentery and the portal vein. So the first thing is always base rate, like always Rabih tells cancer, 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 and then rest of the others. So because the patient was preserved, we thought that cancer is unusual to present initially, but this is a very important thing to remember that cancer can still present this way. So presence of MAHA, cancer can still cause MAHA, but signature of MAHA makes cancer as well as seronegative APS higher on the list. Although 95% we have the routine labs, this is the beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant. There are three other antibodies, which is phosphatidylinositol, annexin A5, phosphatidylethynolamine, and phosphatidylserine, that are being tested nowadays, which is in 5% of patients. And very interesting thought that came up was were we dealing with the actual venous thrombus, or was it all tumor thrombus all along? And the patient finally was diagnosed with stage 4 hepatocellular carcinoma that was sneakily missed in the initial labs and came up further.
Wow, Vijay. Oh my gosh, I wish we do teaching points more often. That was superb. I just love how you narrated the journey along the way at your own pace. You seem so relaxed, calm, and interjected your own tone to it. That was absolutely wonderful. I also cannot believe you rattled off all those antibodies so quickly and so effortlessly. That was amazing. Well, big shout out to Ethan. This was another mind-blowing journey. I'm probably too scared to discuss case number 9 after this one, but I look forward to it. Thank you for subscribing. Vijay, thank you for teaching points, and hope to see you guys next time. Bye.